Yeah, I'm going to talk about the electrophysiological approach in spinal surgery. I have no COI. Especially, I focus on the prevention of intraoperative neurological complication using intraoperative neuromonitoring today. The most critical outcome to avoid in spinal surgery is postoperative paralysis. The risk varies by disease, with reported high paralysis rate of 31% of intramedullary tumors and 32% for thoracic OPLL. Yeah, muscle-evoked potentials, MEPs, for monitoring motor function should be selected for at least one proximal and distal muscle of each limbs, and 8 or more channels are recommended. The alarm threshold of the 70% decrease in MEP amplitude was established by JSS monitoring committee. This threshold minimizes the risk of missing paralysis and allows surgery to proceed without unnecessary stoppage surgery. In this case, a patient presented with left C6 radiculopathy without any muscle weakness. MRI confirmed spinal cord compression at C5-6 with foraminal stenosis. Yeah, in this case, a patient presented with left C6 radiculopathy. During the anterior fusion surgery, MEP amplitude worsened on cage insertion in both the upper and lower limbs. And removal of cage resulted in recovery. So the decision was made to use a smaller cage, which successfully prevented further decline in MEP amplitude. So key point, a large cage is a narrow spinal canal impingement, causes impingement sometimes. The recommended strategy is expand the decompression area to prevent future impingement. And in case 2, the particular had a high ossification occupancy rate of 50%, but maintain normal muscle strength with planned posterior decompression and fixation surgery. Despite completing decompression, MEP's amplitude worsened with no obvious cause. Recovery was observed immediately after rod fixation. So, including the spinal stabilization played a key role in restoring neurological function. So, here is a recommended strategy. Okay, in discussions, the higher proportion of MEP alarms were associated with non-surgical factors, highlighting the need for vigilance in the monitoring and addressing non-special risks. So, OPL placement was associated with lower MEP, and the MEP was more likely to decrease immediately after decompression. The risk of MEP decreases to less than 50% when screws are inserted prior to decompression is higher in patients with severe spinal cord compression with intermediary signal changes on MRI. This suggests that patients with severe spinal cord compression may be more susceptible to waveform changes due to surgical manipulation. Here, positioning plays also a significant role in MEP deterioration. During surgery, it's critical to monitor for nerve injury resulting from excessive fixation or extension during cervical procedure. A Japanese mouse center study reported that monitoring during decompression was able to rescue an alarm in 55% of cases of DCM and 66% of cases for instrument-related alarms. The important point is to evaluate the MEPs needed during critical, so that if an alarm occurs, appropriate intervention can be made in a timely manner. This will help prevent neurological complications without missing opportunities for wave recovery. So what is confusing is that you often experience waveform deterioration even when nothing is done. It's not uncommon for waveform to deteriorate even when there is no nerve damage. No surgical alarm account for a significant proportion of MEP alarms. It's crucial to use a checklist and address vital signs prompt to mitigate false positives. Is monitoring useful in all spine surgeries? The benefit in high-risk surgery is undisputed. However, it may be limited in non-high-risk surgery, and it has been suggested that the risk of paralysis in CSM is low, so the clinical benefit may be small. So, just a moment. On the other hand, a Japanese market study has provided new insight into a positive predictive values monitoring. Monitoring is more predictive in patients with preoperative muscle weakness, particularly in high-risk surgeries. Even for no high-risk causes, weak muscle significantly increase the positive predictive value of monitoring. Currently, in addition to high-risk surgery, poor preoperative motor status increases the paralysis rate, which is in turn increases the positive predictive values. Even in non-high-risk surgery, monitoring is very useful when the patient motor status is poor. Thus, it's not only a question of 70%, but also a future challenge to determine the condition under which monitoring is recommended and approach alarm points criteria. In conclusion, showed how spinal cord monitoring was used to rescue patients during cervical surgery. MEP deteriorations was the cause and timing of MEP waveform deterioration vary. Timely intervention, appropriate and timely intervention is essential to recover MEP waveform and prevent neurological complications. Thank you for your attention.
Thank you, sir.